knows, we will be recording this session so that we can share it at a later time with everybody. All right, Stephen, go ahead.
Okay, great, thanks, Jose. Good morning, everybody. Actually, good afternoon, everybody. It's now 12 o'clock, at least on the East Coast. Welcome to our training session today. Our focus is going to be on health study, and I think that what's happening up in East Palestine right now is a interesting time for this conversation that we're going to have today. So I think it's very timely what we're bringing to the conversation today. And we're going to talk about health studies and some of the things that you can learn from them and some of the things you can't. And we're going to introduce some ideas that we've been working on for some time as an alternative to addressing some of these problems. Just for, the main presenter today is going to be Jose Aguayo. He's our senior science associate, and I'm happy to welcome him and introduce him to you. He's been with us for, I guess, 1.5 years now, but we've known Jose. He started with us probably 10 years ago as an intern at a graduate school in George Mason, and became a fellow, and took a long while to get him in the fold, but we have him now, and changes are coming though down the road. I won't share that now, but changes are coming as we move forward. So, but I'm still excited to introduce Jose and to be part of today's conversation. So, Jose, take it away.
Yeah, thank you, Stephen. So yeah, thank you, everybody. I'm excited to be able to share with you all our presentation on health studies. Last time we had done this presentation was probably roughly almost 1.5 years ago, close to when I started with CHEJ. So we're happy to bring the topic back, but with a new twist. We're really going to be focusing on the limitations of health studies and what CHEJ has done to try to address those limitations in a new approach. Which again, I will be talking about. Let me actually pull out my presentation so that everybody can see it. There you go. I should have everybody here. There we go. So again, I'm excited to be able to run through this presentation with you all. In this presentation, we'll be covering the topic of health studies, the different types of health studies, and really diving into this particular question, right? Health studies, can they give you the answers that you're looking for, the answers that your community is looking for? Because oftentimes that's the first question that we get from communities looking for help, especially from CHEJ's science department. And this is CHEJ's science team, as Stephen had already mentioned. Myself, I'm Jose Aguayo, and I'm the senior science associate here. And Stephen Lester is the science director. We both work with communities, providing technical assistance, and oftentimes tackling this particular question of what can health studies do for communities. And so with that, I want to pose just this question, right? The big question that oftentimes communities come to us asking: can a health study find what's causing your community's health effects? What's causing the disease that you're seeing among your communities? Can a health study do that? So posing this question, I'd like to hear your answers. Feel free to put them either on the chat, or feel free to unmute yourself and go ahead and answer. But I'll pause here. I'll give you guys a minute or so to either answer on the chat or to unmute yourself and go ahead and take a stab at this. What do you think? Can a health study really find what's causing your community's health effects? Please let me know. All right, I see one answer here, and this is from Becky. She says sometimes, but usually we already know what is causing it. And they can't always prove it with numbers. That's correct. Jennifer has said maybe, or at least they can find a partial answer. All right. That's in certain instances for sure. Brenda says that a well-designed study has the potential to answer many questions. Yes, I think that's true in some ways, for sure, at least. Now, Ellie says they're too easily manipulated. And I think you're definitely onto something there, Ellie. And Eve, that's right, Eve, says they cannot identify the source. They can only survey symptoms. Interesting way to put it, for sure. And so I see a couple more answers, several more answers actually, and they all seem to be along the same lines. Matt says it depends on the toxin and how it impacts your health. Linda says not necessarily, but they can help us in certain instances. I will just end this particular section with just reading one last answer from Rachel, who says causation is hard to prove. And Rachel, I think with that, you sum up a lot of what we're going to be talking about here specifically. And I'd encourage you all to remember this. Causation is indeed very hard to prove. And so I will go ahead and move on to the next phase of the presentation and just kind of give you guys our take. The answer is a resounding no. And there are several reasons for that. And in essence, this is really why a health study oftentimes cannot give you the answers, the answers that your community is looking for. There are so many reasons. This is by no means an exhaustive list, but we have kind of broken that down into three really large topics, or three reasons, right? The study designs are inherently flawed. The science behind the studies is limited, and they have one big flaw, that they look for cause and effect. And I'm gonna try to go in somewhat in depth into each of these. But again, remember, these are not all of the reasons why a health study oftentimes fails at giving you the answers that you're looking for, especially when it comes to why your community is experiencing disease, or what is the cause of that disease, right? So first of all, the study design is oftentimes flawed. And what I mean by this is study designs require a lot of things. There are different types of health studies, of course, and we're not really going to go into depth into the different types of studies, but it'll suffice to say that all of them require certain conditions. The majority of studies require large sample sizes to be able to reach statistical significance, as it is termed, right? In order to be able to extend the results to a given population, you need to be able to use a large enough sample size. And oftentimes neighborhoods, communities that may be affected, we're talking about 10, 20 households, sometimes more. But if you have such a small number, it's extremely difficult to then be able to establish this significance, because you have, again, individuals, sometimes 10, 20, 30 individuals who are being affected, or who can be affected, or have been exposed. But at that time, with that small enough number, statistical significance goes out the window. In addition, certain studies require control populations. And these control populations need to be similar to those of the studied population, right? You need a control to be able to tell you how a case without, as the image here says, risk factors or exposures for that matter, right, fares versus a population that is exposed. But oftentimes it's extremely difficult to find a population that matches, especially because the populations that are oftentimes affected are low income, are oftentimes minorities, oftentimes people with some pre-existing conditions as well. And when studies are set up, some of these factors are not taken into account. Some of the vulnerabilities that a population may have are not translated into the control population, and therefore their ability to then differentiate between the two is skewed. Now, going along with this design flaw section, studies require accurate records of exposure to disease. And oftentimes these records, especially in populations where in neighborhoods where they are low income minorities, and where financially the neighborhood is not all that well, these records are oftentimes not kept, or it's extremely difficult to find. And perhaps the last one, the last option here is that study designs can, or our outputs, I should say, the outcomes of a study are easily manipulated by those that are creating the study, that are designing it. For example, a study may exclude a population of workers, for example, because they are also exposed to that particular chemical in their workplace. But these workers are already vulnerable populations because of their extreme exposures, and so their results are removed from the study. You're going to get a false sense of security because you're again removing those populations who are at most that are showing the most symptoms, right? There are multiple ways in which a study can be manipulated, and again, that is a serious limitation. Now, pivoting on to the next set of limitations. This is that the science that these studies use is quite limited. And what I mean by that is current health studies, for example, do not account for aggregate exposures or cumulative exposures, things like multiple chemicals, right? Health studies at this present moment can look at the association or causation between one given chemical and one health outcome, one type of disease, and cannot account for 2, 3, or maybe even a myriad of chemicals that are in the environment that may affect that particular disease or may cause that particular disease. The science of cumulative exposures right now is really barely being developed. And so again, our health studies are the methods that we have cannot account for that. And in a similar vein to that, health studies also cannot account for exposures during susceptible windows of development. Things like children in the womb, right? Or growing toddlers who are at stages in their developmental growth where absorption of certain chemicals may impact their growth, may impact their development in key ways, whereas fully grown adults may not be as susceptible to these chemical exposures, right? Again, our ability to understand how our bodies are affected by toxic chemicals during these developmental windows is almost non-existent. Just like the science, our current understanding cannot account for cumulative exposures, it cannot also account for the effects on the human body of these chemicals during these developmental windows. And finally, one of the biggest things that studies require is the establishment of exposure through things like the route of exposure, how you are exposed to a particular chemical, the dose of that chemical, so how much of that chemical you're exposed to, and the length to which you're exposed to, right? Is it a week? Is it a year? Is it 10 years, right? All these factors are necessary for our current methodology, which is really summed up in what is called a risk assessment. That is really what's used to input all these data points to be able to then make a somewhat accurate assessment or extrapolation of what your health risks will be. But without these factors, without accurately measuring these factors, we cannot then input that information into these risk assessment equations to then be able to get accurate data at the end, right? So again, because oftentimes we cannot with certainty ascertain what the route of exposure is, how a person is exposed, we cannot necessarily estimate correctly the amount of exposure that that person gets and the length to which they are exposed, right? All of those factors mean that risk assessment equations cannot be then used to give you an accurate picture of what your risk of developing a particular health condition will be, right? Like I have here, at that point, it really becomes a guess and not a very good one at that. And now I'll touch on what the biggest limitation really is of our current health study setup, and that is that it's looking for cause and effect. It's looking to establish cause and effect, right? This is what all health studies ultimately look to do, in one way or another. And as I mentioned previously, there are just too many variables that oftentimes just cannot be accurately measured, right? They cannot be accounted for well enough in order to establish this cause and effect relation. And what that means is that because of that, health studies then almost always end up giving you inconclusive results. Either that or they find no causation between the chemical that's being studied and the health effects that are being seen, right? As a matter of fact, not too long ago, CHEJ, we were in conversations with representatives, with reporters, I should say, who are looking to make a piece on what the Agency for Toxic Substances and Disease Registry, ATSDR, on how they handle their health studies. And if I remember correctly, I think the results haven't been published yet, but they found that of the health studies that ATSDR conducted within the past 10 or 20 years, close to 70 to 80% came back with these inconclusive or no causation or association results. And that's a huge number to be able to have a health study in place and 70 or 80% of the time come back and say, we have no idea what's going on, right? So that I think sums up really the problems of our current understanding, our current approach. And through our 40 plus years of work, CHEJ has time and time again just found communities and worked with communities who just found out that these health studies do not answer their questions. They don't empower them, and they don't lead to solutions for their communities, right? And they end up frustrated, disenfranchised. They end up with their health problems persisting on. And so we at CHEJ figured that this can't be the best we can do, right? There has to be a different way. And so CHEJ looked to create a different approach, one that did not use risk assessment, one that avoids all of the limitations that we mentioned previously of our scientific understanding at the moment, and one that does not try to establish cause and effect, but associations instead. And we term this new approach unequal response and equal protection. And this is a campaign that we have been developing for a number of years now, and that we're looking to push and expand on now. And so what this approach is built on, it's a number of things, but probably the most relevant ones for us here is that it contains a defined timeline, one that doesn't keep a health study going on for ages and ages without finding anything or without coming to a conclusion. This approach is also driven by the communities that are affected by what we term a community leadership team, CLT. And it relies upon a methodology called, that we are calling it, Presumptive Association. And this methodology was developed in connection with several public health scientists, epidemiologists, and toxicologists who us at CHEJ worked with to try to improve on the current model. And I'll expand a little bit on what this is. Presumptive association, again, as I mentioned previously, right, it does not establish causation. It stays away from establishing causation and instead looks to establish associations, significant associations that can then be used to justify a response. It relies on a presumptive analysis, which is performed by an independent scientific committee, which consists of environmental scientists, toxicologists, and public health professionals who have no ties to industry or government. In this particular presumptive review board, as we're calling it, performs an analysis that we have fleshed out. Again, I'm not going too much into detail, but at the end, I will share with you guys some of the resources that we have created based on this presumptive association and equal response campaign that can then be, that are much more in depth. But perhaps the key is that this presumptive association makes two presumptions. The first one is that exposure to chemicals that are tested in the environment is established, meaning that if chemicals are in the environment, exposure to them is presumed, right? We no longer have to establish these routes of exposure, these doses. That's no longer a necessary thing, again, because those methods sometimes fail us, right? And then the second presumption is that an association between the chemicals that were established or that were discovered in the community and the disease observed, right? If those chemicals were found in the community and we're seeing disease in the community that is associated with those chemicals, then that presumption is made of association between the two. This is what I really mean about the presumption. Again, the first one, right, is between chemicals and people's exposure, right? And that exposure is presumed, is assumed, in other words, if the chemicals are found in the surrounding environment through testing, right? And that second presumption, which is probably the key one, is that the health effects that are being observed in people in the community are presumed to be linked to the chemicals in the community if the presumptive analysis that the review board that I mentioned before shows a significant association between the two in the literature. And that's where we get a little more technical as to how that presumptive analysis is done. But again, I will share those links and resources with you at the end. So that's really what this presumptive association methodology does. And this is what it gives us, and these are the advantages that it gives us over conventional health studies. Right? Because again, our current methods look for cause and effect, right? And we've established that's extremely hard to do, especially with the current methods that we have. And so an equal response, our new methodology of presumptive association, only looks for associations. Conversely, current conventional health studies, they have several design problems, as we mentioned previously, right? Whereas our unequal response model, it has a simple 8-step design. And again, those design problems are overcome there. Now, conventional health studies also suffer from the science limitations, right? And our unequal response methodology avoids a lot of these. And in addition to our unequal response methodology, it's driven by the communities. It is actually led by this community leadership team that I mentioned previously, whereas conventional health studies are oftentimes driven by health agencies or university experts for that matter, and they're detached from what the community wants or is expecting. And conventional health studies really, again, result in frustrated and disenfranchised communities that do not see their health improve. Whereas hopefully our unequal response methodology results in communities who are empowered, informed, and healthy, right? That is our ultimate goal, to create, to have a response, to have something where communities can improve their health instead of being left with no answers or being told that nothing is wrong with them. And so with that, I will open the floor to questions. Before I go to the questions, I just wanted to take a step back and mention again kind of what Stephen was alluding to at the beginning of the presentation, and that is the situation in East Palestine in Ohio, where we had that tragedy with the train derailment, and how that really ended up with a bunch of chemicals, vinyl chloride being probably the most abundant of them all, being dumped into the communities nearby and being set on fire, and just kind of the result of that, the dioxin that is then being released. And so, Stephen, I just wanted to bring you back in a little bit here, just to kind of talk about how the situation there is being handled, and how our particular model, our particular approach of an equal response could have helped in this particular situation.
Thanks, Jose. I won't take much time because I want to get to questions. Really nice presentation, by the way. One of the reasons we started this whole campaign a couple of years ago was because of the fact that there is no federal response team that's in place to address community-wide exposures, such as what's going on in East Palestine right now. There's no team of epidemiologists, environmental scientists who know what to look for, no coordinated effort and instead you get the kind of chaos that we're seeing up there, where EPA doesn't come in for a number of days, the state takes control, but they don't know what to look for, or they don't want to look for things. You have a vinyl chloride burn occurring in the middle of a community, and everyone who's involved in toxics, particularly the EPA, knows that generates dioxins. That's what you're going to get. And they're not testing for that. They weren't even testing for vinyl chloride. They were just doing vinyl VOCs. But I don't want to get into all the details of what's wrong there. But that chaotic situation is exactly why we started this campaign, so that we don't end up with that kind of chaos whenever there's a community-wide exposure. And so, so we've come up with this unequal response effort. Some of you who are on the phone, I think, were involved in some of that, and it's taken a long time to kind of come to a place where we think we really have put together something that could serve as an alternative. But it begins with a defined response team that has the ability to go in, to do environmental testing, the right testing, and to provide health care and health response and long-term medical monitoring. And then the rest of it comes into play as well. But the response team is a key piece of all this. So I'll just stop there.
Yeah, for sure, Stephen. I mean, I think a lot of the work that we have done, and that's something that I did not go into detailed in this presentation, but a lot of the work that we did with our unequal response approach had to do with establishing a set federal response, right? The one that had a set timeline from the onset of a disaster such as this one to the intervention of a federal agency such as a TSDR or EPA in this case. So again, that's a crucial part of our approach, and that I think would have helped quite a bit in this particular situation. But let me go back to the questions. I saw a few in the chat, and I think the best way probably to handle this is, Hunter, if you could just share the questions, I suppose, in the order that we received them. If the person who asked the question is still on the call, feel free to have them ask the question themselves, and maybe that's how we can proceed.
Okay, I'll start with keeping questions. Dave Walker, how does presumptive association work in activating regulation or remediation? Will the EPA respond without a definite cause?
So, so I think that that's part of the work that we, as a campaign, in the campaign portion of our unequal response project, have to push for, right? One thing that we know is that steering away from causation, right, will give us, will help us avoid lengthy legal battles that oftentimes can slow down processes, especially cleanups or remediations. As for the EPA kind of accepting this, you know, without necessarily establishing causation, that again, it falls down on how much push, how much activism we can generate through this campaign to be able to make these agencies, and Congress for that matter, accept it as a rule. Now, I also should mention, we have modeled our presumptive association methodology on what has previously been used in instances such as the Vietnam veterans or people who were vets who were affected by Agent Orange, for example. Similar methodology was used for them that did away with finding exposure records for them in Vietnam to Agent Orange, and simply relied on having them being served over there for I believe it was a month or something like that, a specific time period. And if they were there during that specified time period, then they automatically became eligible, right? Because their exposure was already given, was presumed. So we've modeled it after that. We've also modeled it after the approach that was used in Camp Lejeune, which is a military base, and where TCE contamination was prevalent. And over there, again, the presumption that was done was the association between TCE and a lot of different health effects that were recorded in the literature. And so no health study was done to try to ascertain the cause and effect between these two. It was simply an analysis of the current literature that ascertained what those health effects were. So again, that's the second part of our presumption that we're trying to establish. So again, it's something that has been applied in other examples previously. We're simply taking that and applying it to communities exposed by toxics.
Let me add.
Okay.
Stephen, go ahead.
One of the things that, you know, sort of answer the question bluntly, no, EPA is not going to just adopt this because it's a good idea. It's going to take communities across the country demanding this kind of an approach. And so that's why we wanted to have a campaign to build support at the level to make these kind of, to educate everybody at all levels, from the communities to the government to the corporations. No, the status quo is not going to want anything to do with this. This is outside the box. And so it's going to take a lot of work to get this kind of idea, but it does build on a tradition of protecting not just the soldiers in Vietnam or the Marines at Camp Lejeune, but the atomic the atomic bomb veterans and the 9/11 victims and firefighters, all of whom are getting compensation of some kind, usually medical, because they've used this assumptive approach and are to recognize their exposure and to recognize their illnesses are connected, rather than to have to prove in a court of law that in order to get anything, that their health problems were caused by those exposures. That's out the window in that case. And we're thinking, well, if it's good enough for the military, if it's good enough for the 9/11 responders, if it's good enough for the firefighters, why isn't it good enough for our people in our communities? And it needs to be, because these people, you all are being exposed not to any fault of your own. This is not something that you all have, decided, okay, I'm gonna put myself in a place where I'll be exposed to this stuff. And so, we can't continue to live and make these decisions based on what government thinks is right. And again, in Palestine, we're seeing what government thought was the right thing to do, and that's to test for volatile organic compounds in a place where dioxins are everywhere and vinyl chloride is everywhere. And so they clearly can't be trusted to do the right thing. And so I think I think our system of evaluating these problems is broken. And I'm hoping we can, through this and other campaigns, begin to help people understand that there's another way to do this. So let's go back to our questions.
Okay. We have a question from David Dow. How does association analysis incorporate other factors like social equity, environmental justice, and climate change that may exacerbate consequences of toxic chemicals on human health?
I think that's a really good question. I don't think that we have necessarily placed, at least in the current iteration of our presumptive association methodology, any specific concerns or ways to incorporate those. I think that's an area where we can still kind of add to the methodology. It just requires, some thinking. But I do think that those considerations can come into place for sure. I think that's an area where we can definitely add to our methodology.
Sorry.
I saw a couple of people raising their hands on the screen here. Perhaps maybe we can go to a few of those. I see Leslie. Leslie, is that right, Leslie? You're welcome to unmute yourself. I think you're muted still.
Can you hear me?
I can now, yes.
I'm a clinician who worked for the visiting nurses in Massachusetts. I had worked in Woburn, which you may have heard of because of the movie A Civil Action. And I worked in that part of Massachusetts for years. In working for the visiting nurses, you go to patients. And in one case, since I was covering a very big geographic area, I ran into a neighborhood where there were 14 families with major neurologic illness. And the one thing they had in common is that all of them were on the side of the street that backed up on the Ipswich River, which is considered one of the most polluted rivers in Massachusetts. And a group of people from the community that I was working with, I worked for the ALS Association, said, could you get a meeting going with the Department of Public Health? Because there's too many of us. The incidence of ALS per year is 1 in 35,000. So 14 cases in 2 blocks is way outside any projection. Anyway, so I did. I ended up with every principal investigator from the Massachusetts Department of Public Health, the people in the community said, we don't want to be on the phone. We want you to deal with this. So I did. I told them what was going on. The answer was, must be a coincidence. Well, you know, from what I know from ALS, that is way, way outside the bonds of incidence. And we got nowhere. And then on top of that, because it was an upper income community, the people in the group were really scared that their home values would plummet. And this has happened all over. It happened in Woburn, but it's happened all over. We work with the CDC on stuff. What I see is that having community involvement, especially community health workers, VNA workers, because we see not only incidents, we see where the families live in relation to the polluting body, be that a river or something else. We can even see that there are more homes, more families who live closest to the river than people who live one block further away. So we have a very, very clear picture geographically of what's happening where. I dealt with VNAs all over the state. They were tracking, they were keeping records of where these cases were. I don't know if community, if this community program is dealing with community health workers. If they're not, I strongly recommend that you do, because our data was very clear. And in addition, I found every time I went on a home visit, the people would stand at the front door and they would point to every single house on that block where someone was sick. They would tell me about every cat and dog living with families that was sick with the same things. And if you know about environmental pollution, you know that animals are just as susceptible. And when you have a cluster where there are as many dogs as people with the same illness, you know there's something going on, because the dogs are not smoking or drinking or doing or working at a job. The animals are kind of a check on whether or not this is environmental. So, I mean, I learned a lot doing that. I'm not an epidemiologist, I'm a clinical social worker, but I think it's really important to bring this up.
Yeah, absolutely. And thank you for bringing that up, Leslie. I think, you bring a couple of points. The first one being, you have ALS being such a rare disease in that sense. And to have a cluster of so many in a given block, it's not coincidence. I mean, they're telling you it's coincidence. Not. It's simply there are so many ways in which they can dismiss those numbers, right? First of all, they can use the sample size thing, right? About, okay, you're looking at so many cases, they just happen to be clustered in the same block, and they can also talk about how can you be sure that those diseases are being caused by the river, right? They're going to try to find ways in which people can be exposed to that river, or even, again, there's so many steps where things can go wrong in the current way in which we establish causation, right? And so, but to address your second point, that the people affected know exactly where all the people who have that disease are, or what's going on. That's another pillar of our unequal response process, in that we give the community the say, and they are the driving force in saying, okay, where should we look? What cases are happening? Who is suffering from this? How do we define the area in which the contamination is present, right? An epidemiologist coming from outside won't know all these questions. They need to be talking to the community, and the community's responses then need to be used to then move the study forward accurately, right? So again, that is one of the components that we have in our process. And the idea of partnering with either social workers or community health workers. I think that is we currently don't have it spelled out in our system, but perhaps that is something that we can include down the future in a way to make the system that much more efficient. So thank you for bringing that up for sure. Hunter, I think we can move to another question. I don't know if people have we can go with stuff on the chat and then kind of go back to something out.
We have Linda who's raising her hand.
Okay, Linda, feel free to unmute yourself.
Okay. Yes, I have I just want to tell you guys about some issues that we've had here in Tucson. I'm in Tucson, Arizona. I grew up in the South Side near the Tucson International Airport Superfund site. Back in 1980s, when the site was placed on the National Priorities List under Superfund, there was a lot of chemicals that were found in our water, including vinyl chloride and other toxic chemicals. But the study or the investigation, they only listed TCE as the primary toxic chemical, but it didn't mean that there was other chemicals there. And I'm wondering if such a program like this or the response this design, I really love it. I've done a lot of research and I've read all of it, and it's greatly appreciated. You guys did a really good job on that. How do communities like ours or that are interested, how can we start the pre-investigation phase? And would we just wait until you guys are, when are we going to move together? Are you guys going to keep us posted on? Because I'm very interested in the program. Thank you.
Yeah, for sure. And yes, Linda, thank you for that. I mean, I think you're referring to the different phases of our study, and again, that definitely shows that you've read up on what we've done. The process itself, right, is we're trying to get it in this campaign phase that we're in to gain enough support to then take it to ATSDR, to the government, and have it be adopted that way, right? So right now, our ability, so we have no ability, no capacity to be able to respond in the way that we have outlined, because that response is predicated on ATSDR to be able to carry it along, right? As far as new developments, I think this is this process we're trying to kickstart it again, to again bring in community support and slowly make a community push to be able to have this particular program or a version of this particular program be adopted by ATSDR, right? But I think it's going to take some time because, as Stephen mentioned previously, the agency is not going to take. It's not going to simply say, "Okay, let me take this over and adopt what you were proposing," right? It's not going to come like that. We need concerted and steady push from communities, from the grassroots, to be able to influence these agencies into taking up this or something similar to this, right? That can improve the current process. But we will absolutely keep you in touch and keep everybody here in the loop as to how that progress goes.
Thank you, Jose.
Yes, for sure. Hunter, what else can we take?
We can do someone else's hand raise, or do you want to do the chat?
I guess we can do one more hand raise and then we should go back to the chat. I want to be able to reach as much as we can.
I think Matt, you had your hand raised first.
Well, thank you very much. I just want to point out, and alert you to the fact that when the industry wants to fight, they bring a lot of powerful arguments in the court. We were involved in an hexavalent chromium contamination case. Everybody thinks Aaron Brockovich's story, they know about it, but the biggest hexavalent chromium pollution has happened in New Jersey. The fight, the court battles took about 20 years, and it took brand new methods, new design methods, to be able to convince that it needed to be settled. But at the end, the settlement was really very inadequate. What I'm trying to say is that what I would recommend, one of the things that I think is overlooked, and when a project starts, there should be an audit of all the methods that are available and make sure that they are rigorous, and the data variation and there won't be any holes in the analytical method, and it can go and be defended in the court. So I just wanted to share that experience that we had and point that out.
Absolutely. Thank you for that, Matt. I think we have worked, again, with several toxicologists and public health people to try to design this. I think there are still a couple areas where we need to figure out the fine print, figure out the little details, and those absolutely matter, Matt. So for sure, we're still working on that. And ultimately, even if we have a foolproof argument, right, we're still going to get pushback. We're still going to get officials who come and tell us it is not scientific enough. It is not based on statistics enough, right? But we know what a system that is purely based on our current scientific understanding of toxicology gives us, right? And there's really more than we don't know than we do know about human biology and its interaction with chemicals, especially when it comes to chemical mixtures. And so, I think that knowing that and expecting that pushback, those arguments, and then developing counter arguments in response, for sure, is going to be, it's going to be beneficial for us in the long run to make this successful. So thank you for that advice, Matt. I don't see any more hands, so we can go to the chat. Hunter.
Okay. Okay, Liz Huntington Mothos asks, as a community engaged scientist, if you want to dive into the presumptive association methodology, what resources do you recommend?
What resources? So there are a number that we can share with you. We compiled a list of, it is not an exhaustive list, but it is a list of the examples, the instances in which presumptive association, or a version at least of presumptive association, was used similar to ours, right? So for example, again, the examples that I mentioned were the Vietnam vets and their exposure to Agent Orange, firefighters in Ohio, for example, Camp Lejeune, in the way that an abbreviated public health assessment was done there by the Agency for Toxic Substances and Disease Registry, ATCR. That's a very good example, and we based our methodology a lot on that one. I can definitely share that list with you, and that can give you a little more information about how we came up with this particular methodology. Any other question? I think we have probably time for one more, maybe.
Yes, let me go through. Go ahead.
Hello.
Hello.
Yes, hi there on the phone. You can ask your question if you have one.
Yes. I was made aware of a nuclear accident that occurred on July 17th, 1970 in an area just south of Eureka, California, a nuclear plant operated by PG&E, Pacific Gas and Electric. And as a Coast Guard, the nuclear accident was covered up, and I did a video that you can see on YouTube, Humboldt nuclear accident. And I was wondering, we have had a number of people do a survey of people downwind of this accident, and some of the families in the area were almost completely wiped out by cancer. We're talking 4 out of 5 people. And what would it take to get the EPA to do a study of a nuclear accident that old?
So to answer your question, well, to answer your question, I'm not sure that a health study at this point would do any good. We kind of talked about, why a lot of the variations of different types of health studies have limitations that mean that ultimately they come up with inconclusive results, right? One of the biggest ones is their lack of accurate records. If we're talking about an accident that happened in 1970, the availability of records, health records, exposure records from that time, I guess I'm taking a guess here, but I'm guessing that it isn't very much available. And so if that's not the case, doing a retrospective study to try to see, the health effects that people have developed since who were present or exposed at the time becomes extremely difficult. So again, my advice at that point to you would be, are those records available? Are they trusted? Are they accurate? And even if they are, what do you expect to gain from such a study, right? One thing that I perhaps didn't mention previously is that even when you do a health study, even when you decide to do one, you have to do so in conjunction to whatever your group's goal is, whether it's to get relocation, to get media attention. What that goal that your group has to dictate what your study does, right? When it comes to community science. So I didn't catch your name, but you're welcome. I'd love to connect with you later on and just kind of discuss if CHEJ can help in any way. Could you let us know your name, please?
Sure. My name is Scott Rainsford, and I was a Coast Guard reservist after a number of years operating laboratories on board several vessels.
I see. Okay.
And I was sent to the reactor to see if I could update their contingency plan. And I was an oceanographer meteorologist for the Coast Guard at the time. And I went to the reactor about in October of 1977 and read their plan and then asked if they ever had a chance to use it. And they brought out a report marked confidential that was written by one of their nuclear engineers named Schiffer. And he, when the accident started, he took command of the reactor and wrote a log, the nuclear operator's log. And the log that I read was stunning. The reactor became so out of control, the military had to take over direction of the plant to get the reactor back under control. And eventually what happened is they had to vent the reactor of the buildup of hydrogen gas to prevent an explosion like you would see at Fukushima. And there's an elementary school 400 yards downwind of that accident. And the nearest house is about 700 feet from the reactor. And there's several communities in the area. And this was clearly a cover-up. And I say that because in the past, I have tried to get a copy of that nuclear operator's log. And the Nuclear Regulatory Commission said, oh, those logs are missing. And the United States Congress, the Joint Committee on Atomic Energy,
I'm sorry.
reviewed the.
We need to wrap up. Our session's over here. So I think it'd be great if you and Jose can have a one-on-one to go into this in more details. I'm sorry to cut you off, but you know, we're done at 1 o'clock. We're at 1:05. So I want to thank everybody for being here, for participating. We will share the presentation and some information about our unequal response campaign. Jose, you have the last word if you want to wrap up.
Yes, of course. And yeah, thank you. And Scott, again, I'd love to connect with you. If you can email us at CHEJ@CHEJ.org. Again, that's CHEJ@CHEJ.org. I know you're on the phone, so you won't be able to see anything on the chat, but we can connect that way. But yes, so thank you for that, Stephen. It was, thank you everybody for being part of this. We will share the resources, both the recording of this presentation along with our unequal response resources as well. And we will welcome any kind of questions that you've had that we haven't been able to get to as well. So I will share my email with everybody when I send the resources. So feel free to connect with me that way. But again, thank you very much. And we look forward to seeing you again at our next training. Thank you.